Subsequent to the recording of this meeting, the FDA granted approval on June 18, 2025 to tafasitamab in combination with lenalidomide and rituximab for adults with relapsed or refractory follicular lymphoma. The approval was based on the results of the Phase 3 InMind trial.
Well, good evening, everyone, and welcome to Cases from the Community. Investigators discuss available research guiding the care of patients with non-Hodgkin lymphoma. I am not Neil Love, but I am honored to be sitting in his chair. I'm Jeremy Abramson from Mass General, and will be moderating tonight's program. And I'm particularly honored to be joined by four of the finest lymphoma specialists in the world. That includes Dr. Joshua Brody from Mount Sinai, Dr. Ann LaCasce from Dana-Farber Cancer Institute, Dr. Tycel Phillips from City of Hope, and Dr. Chris Flowers from MD Anderson Cancer Center. Here are our disclosures that we'll run through pretty quickly, particularly that one. And then we'll show Dr. Love's disclosures, who will be making appearances via video. And here is the commercial support for today. Research to Practice CME Planning Committee, staff and reviewers have no conflict of interest to disclose. Today's program will contain discussion on non-approved uses of agents and regimens. Please refer to official prescribing information for each product for approved indications. In advance of today's program, Dr. Love interviewed 9 general medical oncologists who presented cases and posed questions on a number of key clinical issues of interest. Video excerpts from those interviews will be featured throughout tonight's program. And this is what we're going to cover this evening. We're going to start with Dr. Flowers discussing diffuse large B-cell lymphoma. Dr. Phillips will then talk about management of mantle cell lymphoma. Dr. LaCasce will take us through follicular lymphoma. Dr. Brody will address the integration of bispecific antibodies. And then finally, I will finish with a discussion of CAR T-cell therapy across the lymphoma landscape. So now we'll move to our very first module and invite Dr. Flowers to present on diffuse large B-cell lymphoma.
Great. Well, thanks, Dr. Abramson. It's great. My great pleasure to talk with you today about some of the recent advances in the treatment of diffuse large B-cell lymphoma. I think as all of you are familiar with the landscape in the first line for diffuse large B-cell lymphoma, had its first change in about 20 years with the publication of this study that used the drug, the CD79B antibody drug conjugate, polatuzumab, as a substitution for vincristine in the standard R-CHOP regimen, where this trial, the Polarix trial, was a randomized controlled trial of those two particular regimens. And what this slide shows is that trial met its primary endpoint with improvement of progression-free survival, ultimately leading to the approval of Pola-R-CHP as a standard of care frontline regimen for patients with diffuse large B-cell lymphoma who have an international prognostic index of 2 or greater with a hazard ratio of 0.73. What we've seen more recently is Gilles Saul presented an update of that trial with a 5-year analysis of the Polarix study, which is now moving toward publication, showing that both within the population that I just showed you on the slide previously and an extended population, that this progression-free survival benefit was sustained and maintained over this period of time with additional 5 years of follow-up. And I think importantly to know is that with the major toxicity of polatuzumab being neuropathy that is typically seen after more than 6 cycles of therapy, and only 6 cycles of therapy were given in this study, that across all the major adverse events, that those appear to be quite similar across the 2 arms of the study, with the exception of slightly more neutropenia, but that did not translate into a greater rate of infections for the group that had Pola-R-CHP versus R-CHOP. I think some of the questions that have remained about this regimen really stem from the subset analyses. There was a publication in the New England Journal of Medicine from the group at Stanford that looked at the subset that has ABC subtype of diffuse large B-cell lymphoma and in the primary publication, you can see that that's also one of the subsets. I think it's important to notice that when you classify ABC in these analyses, this was always done by gene expression profiling. And with immunohistochemistry classifying the non-GCP subset, there's approximately a 20% misclassification. And so if you're able to do classification by gene expression profiling, I think these data stand out. When we're not able to do classification by gene expression profiling, I think it calls into question whether or not we should be using cell of origin as a basis for making decisions about who should receive therapy. The next set of data I'll turn to very quickly are around CAR T cells that have changed the standard of care in second line for patients with diffuse large B-cell lymphoma. You'll hear more about this in Dr. Abramson's talk, but really what is shown here are two randomized controlled trials, both of which showed a benefit in progression-free survival, and the ZUMA-7 trial ultimately showed a benefit in overall survival for the use of CAR T cells for patients who have early relapse of their diffuse large B-cell lymphoma versus the conventional standard of care using additional salvage therapy and high-dose therapy and autologous stem cell transplant. This trial really stands to reason in that if patients are not responding to conventional chemotherapy and have an early relapse, that giving more therapy and giving high-dose therapy and transplant really essentially provides no benefit for those patients compared to CAR T-cell. What's relatively new are these data from my colleague, Michael Green, that come in this trial that will come up next. First, turn you to the algorithm. So the algorithm essentially based on those two trials suggests that for patients who have an early relapse of their disease, so within the first 12 months after first-line therapy, and are eligible for CAR T, should proceed on to CAR T-cell therapy. And those patients with later relapse should consider autologous stem cell transplant still. What's new are these data that I'll mention that come from my colleague Michael Green, where he's done single-cell sequencing now of more than 230 patients with diffuse large B-cell lymphoma in the frontline setting and in the relapse setting, and defined three molecular subtypes of diffuse large B-cell lymphoma. One that's enriched for fibroblasts and macrophages called the FMAC subtype, one that's enriched with a typical lymph node signature that is shown there as those that have typical CD8 and CD4 lymph nodes, where the circles show the subtype of the disease, the subtype of the component of the lymph node that's involved, and the size shows the amount of that relative subtype. And then a third subtype that is called the T-exhausted subtype, or the TEX subtype, not TEX for Texas, but TEX for T-exhausted. And those typically have a CD8 exhausted phenotype as well as a macrophage signature. And I think what's interesting about these biological data is that they've now been synthesized into a gene expression profile and then projected onto those clinical trials where what was presented at ASH and will be presented in more detail in the plenary session at the Lugano meeting is that if you look at patients within the ZUMA-7 trial who have the traditional lymph node subtype, which makes up about a third or more of patients, that those patients had a clear benefit for getting CAR T-cell. Likewise, the patients who had the FMAC subtype also had a benefit, but patients who did not, who had exhausted T-cells in their lymphoma did not have a benefit for CAR T-cell. Now, these are provocative data and the kind of data that help to design strategies for future CAR T-cell development, but also may help us to understand therapies in the future. Next, I'll turn to therapies in the relapse setting. And so these are data from the original use of polatuzumab vedotin in the relapse setting for diffuse large B-cell lymphoma, where pola-BR showed a benefit of overall survival versus bendamustine rituximab. And these are further follow-up data to that study that showed in that randomized cohort with additional follow-up that they maintained a benefit in progression-free survival with a median progression-free survival of approximately 9 months for the pola-BR group versus approximately 4 months for bendamustine rituximab, and an extension cohort that essentially showed the same sort of outcomes with more patients enrolled in a single-arm study. Likewise, when you look at the safety profile of this is a regimen that was reasonably well tolerated and had as its major adverse event being neutropenia, with about a third of patients having grade 3-4 neutropenia occurring and about 22% having infections as an adverse event. I will skip through this slide because we'll go through all the data for that. The next regimen that I'll turn to in the relapse setting is the combination of tafasitamab and lenalidomide with additional follow-up that was just recently published at the tail end of last year, looking at the 5-year outcomes for this study, with 5-year data showing an overall response rate of 57% and a CR rate of 41% for those patients. And what you can see is that when patients receive this regimen in earlier lines of therapy, that as expected, the progression-free survival was quite a bit better. Likewise, when you look at the safety summary for this study, that the majority of the adverse events occurred during the time period when both lenalidomide and tafasitamab were given. And then you look in those later boxes to the right, you can see with tafasitamab monotherapy, there was relatively limited toxicity for patients seen in that portion of the trial. The next agent that I'll turn to is loncastuximab tesirine from the LOTUS-2 trial. So this was an open-label, single-arm study that looked at getting loncastuximab first for 2 cycles at a higher dose and then at a more standard dose for the remainder of therapy with additional follow-up of those patients. And you can see now with the follow-up publication of those data for patients who had responses on that trial that both the progression-free survival and overall survival look quite favorable. That's shown in the blue curves. However, for the remainder of patients in the group, that progression-free survival looks better than what has been seen for standard therapies with a median overall survival of approximately 9 months. And these show the adverse events for this particular regimen. What is interesting about this is the GGT increase, which you need to be aware of for patients who receive this agent, as well as the peripheral edema, which can be unique that occurs with this agent as well. And then the next study that I will turn to is the use of brentuximab vedotin with relatively recently published data looking at that combination with lenalidomide rituximab versus the combination of lenalidomide rituximab in patients who had 2 or more lines of therapy for diffuse large B-cell lymphoma. And what you can see here is that this study met its primary endpoint with an improvement in overall survival for the group that received brentuximab with their lenalidomide and rituximab, creating yet another option for patients in the relapse setting. This agent, as has been seen in other settings, has been associated with neutropenia, also has peripheral neuropathy as the unique side effect that adds, with peripheral sensory neuropathy occurring in approximately 20% of patients. And finally, I'll turn to the role of BTK inhibitors, which are under investigation in diffuse large B-cell lymphoma. And this trial that is looking in the first line to add acalabrutinib to R-CHOP versus placebo plus R-CHOP that hopes to provide yet another option in the first-line setting for patients with diffuse large B-cell lymphoma.
Terrific. Thank you, Dr. Flowers. And now we're going to turn to some case presentations introduced by Dr. Love. And we're going to start with a case from Dr. Giffey.
Good evening, everyone. I'm Neil Love from Research to Practice. To enhance the clinical relevance of this meeting, over the last few weeks, I met in individual Zoom recording sessions with community-based general medical oncologists, Drs. Spencer Backow, Warren Brenner, Shams Buffalino, Gigi Chen, Victoria Giffey, Neil Morgenstein, Shaker Pelez, and Syed Zafar to present cases and query the faculty on the stage about their experiences and relevant research findings, beginning with Dr. Giffey, who presents a patient receiving first-line treatment for GCB-type diffuse large B-cell lymphoma.
This gentleman was a 51-year-old detective, was found to have extensive diffuse large B-cell lymphoma involving his stomach wall. She actually had it in multiple extranodal sites, both kidneys, spleen, liver, lungs, pancreas, and his stomach, as well as all lymph node basins. So I gave him Pola RCHP, improved symptomatically almost immediately. He already had a complete metabolic response halfway through, gave him a full 6 cycles. I was concerned that he would need intrathecal, so I sent him for an opinion. And the academic center said that you can give 1 dose and check the CSF, and we did that, and it was negative, so we only got the 1 dose of intrathecal. And he has had ongoing CR since. He's a couple years out. My question was, this gentleman was a very fit detective at diagnosis, drinking plenty of water the entire time, and had a rising creatinine steadily throughout treatment. And after treatment, it never came back down. So I was curious if the investigators have seen this. Is there anything to do to prevent it? Do they find any long-term problems from what is now permanent renal insufficiency?
What is his creatinine?
1.8. It's not terrible, but his baseline was 0.8.
Any questions about CNS prophylaxis?
So I've been out of training about 10 years, and I feel like the pendulum has fully swung from giving it to any high-risk patient to almost not giving it at all. I was a little bit surprised at the recommendation of doing it one time. I'd love to ask 10 investigators what they would do in this case, where this guy clearly has multiple sites of extranodal disease.
Any other questions?
It is difficult to try to decide between R-CHOP and POLA-R-CHP, and I'm curious if there is a way that you not only take age, but organ function and comorbidities into account.
Yeah, so that's a great case. Lots to dive into in that case. The first question, why don't we, Chris, just ask. I got to tell you, renal dysfunction has not really been on my radar screen for POLA-R-CHP. What's your experience?
Yeah, not something that I've really seen either. It's a little bit surprising in this particular case, and I think it sounds like she did everything that I would have done in the care of this patient, and just an untoward event that was unexpected.
That's interesting. So has anybody on the panel sort of come across renal insufficiency? Rare things happen rarely, of course. Dr. Phillips, we now have this situation where we've got POLA-R-CHP or R-CHOP as initial options for IPI-2 and above DLBCL. How are you making that decision in your practice?
At this point, we're not, because we have clinical trials to put the patients on, but...
There's no copping out in this format. Tycel, you got to give an answer.
Yeah, sure. Dogmatically, when the study first came out, I was religiously GC, non-GCB. I think from maybe this past ASH on forward, I've just been given POLA-CHP.
And so why don't I open it up? Are people using cell of origin to determine whether to incorporate POLA or not and limiting it? I'm seeing a negative from Dr. LaCasce.
We use HANS, as was pointed out. You know, if you were doing a molecular subtyping, maybe that would be different. I think we're going to hear some more data at Lugano about this topic that, you know, eventually may shift, but we sort of follow what the study did.
And the study was high-risk IPI-2 and above DLBCL, and I think most of us would still reach for POLA-R-CHP in our high-risk patients, though probably more enthusiastically in an ABC patient. Dr. Brody, this sticky wicket of CNS prophylaxis came up. We heard about a swinging pendulum. I saw a lot of nods on the panel when Dr. Giffey brought that up. What's your approach to CNS prophylaxis?
So you chose to give me the hardest question?
Well, I'm just surprised you didn't run away when the detective was mentioned.
Yeah, I didn't realize there were going to be... that's one of these questions where we say a lot more was known about this a few years ago. And I think, the pendulum has swung, but we didn't have the right answers then, and we don't have the right answers now because it's hard to get high-level data. We have CNS IPI. Well, now we've had it for a little while. And, we do prophylax for high CNS IPI patients, but there's not a black and white because we try to prophylax with systemic high-dose methotrexate, and a lot of our patients are 75 is the new 74, but still a lot of our patients don't have perfect kidneys and wouldn't tolerate it well. So there are shades of gray. There's not an exact CNS IPI that they need to get it. And yes, this patient had a lot of extranodal disease. I didn't specifically hear about the highest risk extranodal sites. I heard liver and spleen. So I'm not sure what that person's CNS IPI was. We probably give methotrexate CNS prophylaxis to 10 to 20% of our first-line DLBCL patients.
Yeah, and it's certainly something we can predict risk. We can't necessarily prove that we can mitigate that risk. Dr. Flowers, what's the approach at MD Anderson?
Yeah, it's really been a challenging and ever-changing approach. I think we can say what things you cannot do or should not do. I think we know that if you give prophylaxis with intrathecal methotrexate, that does not change your risk in retrospective studies. We know now that if you give high-dose methotrexate, that also probably does not change your risk appreciably for the standard risk patients. I think the rare patients that it's important to think about are those patients with testicular ventricular involvement or paranasal sinus involvement where there's a high likelihood. In those settings, I think it's still dealer's choice about what you try and do to try and change that risk. I have a detailed conversation with the patients. What I personally do is try and do something else, and that's all typically alternating therapy with more than one agent, using ARAC and methotrexate for prophylaxis, but really knowing that I may not be alternating that risk in any particular way.
Now, Dr. Phillips, this is a rapidly moving landscape. We heard from Chris about the Escalade trial coming up and the potential role for BTK inhibitors. There are lots of other ongoing frontline studies, including things like bispecific antibodies, CAR T cells, golcadomide, zilovertamab. What are you most excited about? Look into the future for us.
Yeah, I think with the cornucopia of studies that we have, it's a little bit interesting. I mean, I think a lot of us have a lot of interest in the bispecifics just because obviously these are things that can easily, likely, hopefully translate into the community setting. It's things that we haven't necessarily done before. I mean, golcadomide, we've done lenalidomide. The BTK inhibitors, we've sort of done that before. And on CAR T, for the most part, will still be centered in academic sites. So I think as far as, the distributing sort of out to a larger audience, I think the bispecifics have the greatest potential, especially with some of the mitigation strategies of chemo first and bispecifics integrated later to mitigate the CRS risk.
Yeah, I think polatuzumab with RCHP has whetted our appetite to move beyond traditional R-CHOP, but there's still plenty of room to move and a lot of excitement going on. So let's go to our next case.
The next case, presented by Dr. Pelez, focuses on a common situation, the management of first relapse in diffuse large B-cell lymphoma in older patients with comorbidities, such as his 83-year-old woman with multiple cardiac issues.
She received 6 cycles of R-CHOP, attained a CR, remained in remission for about 7 or 8 months, at which point she presented with a lymph node mass in her upper extremity that was biopsied, and it was a recurrent diffuse large B-cell lymphoma. She has some cardiac comorbidities, mitral valve disease, and has had a couple of admissions for congestive heart failure since finishing R-CHOP. Clearly wasn't a candidate for aggressive therapy. I recommended lenalidomide tafasitamab. She achieved a complete remission with that, completed the 12 months of lenalidomide. We did have to dose reduce her along the way because of recurrent neutropenia, and she remains on tafasitamab infusions every other week and remains in complete remission.
Wow.
Yeah. So, I guess almost 3 years from starting this regimen. So questions here would be, what's the data with lenalidomide tafasitamab? What was the median duration of response on that study? I suspect she's exceeded that. Would you consider discontinuing therapy on her at some point? She tolerates it well, but it's fairly frequent infusions that she comes in for.
So very interesting case. Ann, let me ask you, this is an exceptional responder to TAF-Len, and these certainly happen, but we've also seen a retrospective analysis where the results were not nearly as rosy as the data that Chris presented. Who is the right patient for TAF-Len?
So I think in that original study, those were, pretty well-selected patients. They weren't primary refractory. The LDH was not, the percentage of patients with high LDH was relatively low. The real-world data, as you mentioned, looks much, much worse. She wasn't primary refractory. Obviously it was a good choice for this patient, but I think that the inconvenience of the schedule can also be an issue. And I think now we might think about trying to get someone to STARGLO or to get a bispecific antibody. It sounds like this patient may have been borderline for even that type of approach. They did a nice job of getting this patient in probably a durable remission, and I would probably stop the tafasitamab at this point. I don't know that there's really any biologic rationale for continuing with an aggressive lymphoma.
Yeah, we're seeing so many advances, and now you're going to hear about CAR T cells and bispecifics moving more into the second-line setting, which leaves us with things like Pola-BR, Tafelen, Long-Castuximab, potentially in the third-line and later setting for many patients. Dr. Brody, how do you think about going back and forth and choosing among these different targeted options?
Dr. Abramson, I'm going to answer your question, but first I want to answer a question that you didn't ask me, which is 83-year-old, it's the new 82, but the cardiac comorbidity was the emphasis there in this patient. And we should give a little credit to a trial that I personally, maybe a bunch of us, maybe under-acknowledged in the beginning because it was published in JAMA, not a classic oncology periodical, which is that the initiation with the frontline therapy, this is second-line therapy, but the initiation with frontline therapy for those patients who are not on atorvastatin or possibly, other HMG-CoA reductase had a significant decrement in a percentage of patients having greater than 10% EF reduction. This is 2.5 years ago in JAMA. I apologize, I forgot the first author's name, but we didn't see that when it came out. Thank you. Yes. And, months later we said, oh, yeah, so we finally institutionalized or, operationalized that for all these patients. Most of them are already on Lipitor, atorvastatin. But for those who aren't, this was a big deal for for all patients, but especially 83-year-olds with cardiac comorbidities. So I want to acknowledge it for that patient. I don't know if we're going to bring it up otherwise. How do we choose between all these things? It is very tough, and it's a rapidly evolving space. And, not to answer Dr. LaCasce's question, who's the right Tafelen patient, but that answer is evolving with the Echelon 3 data that Chris presented, because you're not going to give lenalidomide twice, right? So if you're going to give it once, obviously the different FDA approvals in second line, third line, or different trial studies, but you're not going to give it twice. And one of those studies has an overall survival benefit, and one of them is a single-arm study, which was not reproduced well in the real-world evidence. So I think who is the right Tafelen patient, who is the right Len patient, and then the partner of Len might be the thing that has a randomized overall survival benefit nowadays.
Well, I think it's probably safe to say if you, as a patient, you were going to treat with lenalidomide rituximab, adding in the brentuximab vedotin would certainly make sense based on Echelon 3. Tycel, let me come to you because we heard about a lot of dose reductions of the lenalidomide in this patient. What's your experience, and when do you dose reduce, and how do you do it?
Early and often. Lenalidomide is a very difficult drug.
I asked about Len not voting, but we are in Chicago.
I am from Chicago, so. But no, dose reductions are something that happen. Typically, lenalidomide as we get older is very difficult to tolerate, and so then patients if I start at 20, I will go down very quickly, 15, 10, until we get an appropriate dose. And in this situation with a patient in a complete response, I wouldn't hesitate to stop and just continue, if anything, with the tafasitamab. But as Dr. LaCasce has already said, even that, I think you can legitimately stop.
Great. Let's go to our next case.
The next patient, presented by Dr. Bacow, is an 87-year-old woman with recurrent diffuse large B-cell lymphoma who was primarily refractory to axi-cell CAR-T treatment and the bispecific epcoritamab.
She was switched to Long-Castuximab, and shortly after that, she had near complete resolution of disease. The problem is that she was having a lot of side effects with cutaneous toxicity and significant fatigue. So my question for some of the experts is, how do you manage patients that have an excellent response to Long-Ca-T or Long-Castuximab tyrosine that develops substantial cutaneous toxicity? Are there any medications or remedies that we could use prior to starting treatment or while on treatment to help reduce the incidence of toxicity? Do you ever take patients off of Long-Ca-T and monitor them after they obtain a complete remission?
So she receives axi-cell in her 80s, no response, and then a bispecific?
Yeah. And she's appeared also to be refractory to epcoritamab. Has anybody ever used Long-Ca-T after receiving CD19, CAR T-cell therapy, and bispecific therapy?
How long was she on the Long-Ca-T?
It was about 1.5 years. She left and went on hospice eventually, but she wasn't progressing. She was getting older, more cognitive impairments. She was taken off and ultimately went on hospice, but I don't think she died from her lymphoma.
So that's another fascinating case. Patients gotten a lot of different therapies for their large cell lymphoma. Chris, this is a patient who got a CD19-directed CAR, a CD20-directed bispecific. Do you have any qualms about going to a CD19-directed ADC with Long-Castuximab?
Yeah, so maybe just go back to the beginning of this particular situation. I'm assuming that if she got in the second line therapy, that she had primary refractory disease that led her to get the CAR as a second line therapy. And so this is a very poor prognostic situation to have failed primary therapy and had an early relapse, to have failed CAR T, and then to have had a CD20 bispecific fail the patient as well. And so a little bit surprising that she had a response in this setting, but we do see that. In about 25% of patients, we see that the failure of CAR T is due to loss of the CD19. And so there are other patterns of failure that are not due to that. And so going back with a CD19-directed therapy in those situations is a viable option for some patients.
So let me stick with you, Chris. If you had a patient who was just treated with a CD19-directed treatment, are you biopsying to look for CD19 before another CD19 therapy?
Correct, yes. So we would rebiopsy those patients and look for CD19 and CD20 in every round of therapy as you're trying to choose these bispecific antibodies and CD19-targeted therapies.
Tycel, this patient had a severe rash. There are some funny toxicities with Lonca. This volume overload, you need to pre-medicate with dexamethasone, this GGT we heard about. Have you seen this cutaneous type reaction with Lonca?
Yes, and typically it's driven by sunlight. So I encourage vampirism. Patients, they can come out at dusk and go in at dawn. So it's really, they have to limit sun exposure, hands, feet, any part of the body. Even riding in a car. I mean, so these are things that you constantly counsel patients about. Sunscreen is just not enough. They need to have loose clothing, gloves, and things like that.
But just the sunlight part of the vampirism, not the whole...
Blend, yes.
Okay.
Just the sunlight.
Making sure I know what to recommend.
Yeah, and garlic does not actually help deal with it. Okay, fair enough. And, loncastuximab was studied for a year of fixed therapy. When do you continue loncastuximab, Ann, or would you continue it in the absence of progression?
I mean, I think it's a real balance, and you have to look at the patient in front of you. And if someone's not tolerating it like this and it's interfering with quality of life and they're in complete remission, then I would certainly think about discontinuing it. This patient has had a remarkable response. I think this is a little bit unusual compared to what I've seen, but I would stop.
All right. Let's move to our next module on mantle cell lymphoma and turn it over to Dr. Tycel Phillips.
Thank you. All right, so there's been a lot that's changed in the last year with MCL. So we'll go through some of this very briefly and discuss some of the key points. So ideally, this slide is here just only one reason, and it's just that observation is okay in patients. So if you have a patient with mantle cell lymphoma, you do not have to feel obligated to treat the patient at diagnosis, especially if the patient is asymptomatic. I think we've had 3 or 4 publications now that have justified that observation does not detrimentally impact patients' outcomes, and it gives them more time off therapy to determine whether they actually need to actively be treated or can be monitored long-term. But if we want to look at patients with treatment, which I'm sure why you're here, if we look at an algorithm, sort of the age of transplant, this is really heavily based on chemoimmunotherapy and obviously consolidation with an autologous stem cell transplant, which is basically an autologous rescue after high-dose chemotherapy. Everything that's sort of been presented here was sort of as a lead-in to getting most of these patients into a remission to consolidate with an auto transplant, except hyper-CVAD. A lot of us were sort of astonished when the German Triangle study came out because this actually looked at eliminating autologous stem cell transplantation in the front-line setting. So just to recap of how this trial was designed, it was designed to determine if you added ibrutinib to the arm with transplant, they develop a superiority. And on the counter arm, if you had the arm that did not include autologous stem cell transplantation but did include ibrutinib for 2 years of maintenance, was this not inferior to the arm that would concluded autologous stem cell transplantation alone, considered to sort of the standard of care? So from the initial presentation, this ideally showed that there was a benefit to add an ibrutinib in both arms. So the arm that had auto plus ibrutinib was better than the arm that did not include ibrutinib. And then the arm that had ibrutinib but did not include autologous stem cell transplantation was not inferior to the arm that included the autologous stem cell transplantation but not ibrutinib. So more recently, they provided more updated data. As you can see, it still holds true that the addition of ibrutinib for 2 years in this younger patient population, the key point here are these are patients who were transplant eligible, so they were typically 65 and younger. These patients with the addition of ibrutinib for an induction, only with the R-CHOP and then 2 years of maintenance, had an improvement over the standard of care, which is high-dose chemotherapy, R-CHOP, alternator R-DHAP, followed by autologous stem cell transplantation. In both of these situations, there was no convergence of the curve, so even longer follow-up, the failure-free survival sort of maintained. Again, if you looked at whether autologous stem cell transplantation plus ibrutinib had a benefit over ibrutinib, there was no statistically significant difference between these two arms, suggesting that we could safely get rid of an autologous stem cell transplantation. But there is some caveat. There were some high-risk subgroups here that they further investigated, and specifically patients with blastoid variant mantle cell lymphoma. It did appear that there was a slight benefit to include an autologous stem cell transplantation in those patients with the addition of ibrutinib. But ideally, there's a rare patient population, and some argue that the additional benefit is not worth the toxicity that comes with combining auto transplant plus the 2 years of ibrutinib in this patient population. I think the bigger key point from here is there was an overall survival benefit to the arms that included ibrutinib. This is something that we rarely see in mantle cell lymphoma. So in this situation, the two arms that included ibrutinib for, again, induction and then maintenance had an overall survival benefit over the standard of care arm, which was just R-CHOP, R-DHAP, and autologous stem cell transplantation. And so from that, what we can sort of contrive from this, plus the more recent ECOG study, is that autologous stem cell transplantation is pretty much a dead modality in mantle cell lymphoma. So for the most part, these are not patients we will be referring for autologous stem cell transplantation consolidation any longer. It will either be a situation where you can consider these patients on R maintenance based on MRD analysis, or you can take these patients just 2 years of ibrutinib maintenance without the use of a minimal residual disease test. So if we look at the young fit patient population as of now, as you can see, the age of transplant is over, and so we're looking at these sort of novel treatment options that include BTK inhibitors in the frontline space, or as I mentioned before, you have the option if you use the adaptive MRD assay to sort of eliminate the use of auto transplant in patients who are MRD undetectable, but use rituximab maintenance for 2 to 3 years in that patient population. Now, if we look at older patients, this is a patient population that's proven a bit more difficult. Obviously, these are patients we could not take to a stem cell transplant previously. And these are patients where we know implementation of BTK inhibitors has sometimes caused adverse reactions, especially as we sort of extrapolate what we saw with large cell lymphoma with some of the early trials looking at R-CHOP plus the BTK inhibitors in this patient population. But as you can see from the drugs listed here, these are all moderate chemotherapy regimens, VR-CAP, R-CHOP, and then BR plus or minus maintenance rituximab. So the first stab at trying to improve this patient population was a SHINE study. This was a randomized study that added ibrutinib to patients with bendamustine, so bendamustine rituximab plus ibrutinib for 6 cycles, and ibrutinib until intolerance or progression versus BR followed by ART maintenance in this patient population. This study did not allow any crossover, so patients on the standard of care arm were not allowed to cross over to a BTK inhibitor at relapse. And so the study did meet its primary endpoint, so there was a progression-free survival benefit. But unfortunately, if we look at this, there was a diminished shine from this as there was no survival benefit in this patient population due to unexplained toxicity in the experimental arm. So there were unexplained deaths in this experimental arm, which we postulate were related to toxicities from the continued use of ibrutinib in this older patient population. And so from that, we sort of look at this as a failed attempt. Unfortunately, this did not work out and led to the withdrawal of ibrutinib from the U.S. market. So another sort of attempt to sort of improve on this was the ENRICH study. This was a study from the UK. So this study randomized patients to either R-CHOP or BR. R-CHOP, BR, which was investigator's choice versus ibrutinib and rituximab. This was also for an older patient population. So these were patients who were considered to be transplant ineligible. And so from this, the initial announcement from the ASH conference was that ibrutinib rituximab was better than chemoimmunotherapy. So as we'll see in these slides, that is true to a point. So ibrutinib rituximab does appear to be better than R-CHOP in this patient population. But as you can see, there is no statistically significant difference between ibrutinib rituximab and bendamustine rituximab. And the key point here is that the ibrutinib in this clinical trial was continued until progression or intolerance. So you have 6 months of therapy plus or minus maintenance therapy versus an indefinite therapy with ibrutinib in this patient population. And again, if we look at overall survival, there was this overall survival benefit in patients compared to R-CHOP, but not bendamustine and rituximab. And so from this study, you can sort of subjectively say that ibrutinib rituximab is better than R-CHOP in patients with mantle cell lymphoma who are ineligible for autologous stem cell transplantation and equivalent to what we see with BR. Now, there are also some caveats here. For patients with P53 alterations, ibrutinib rituximab did appear to be better than both R-CHOP and bendamustine rituximab. But in patients with blastoid variant, bendamustine rituximab appeared to be better than ibrutinib rituximab for this patient population. So there is some selectivity in this situation. So lastly, for this elderly patient population, we'll talk about the ECHO study. So the ECHO study was sort of a duplicate of SHINE, except in this situation, there was crossover allowed. So if patients progressed on the standard of care arm, they were allowed to cross over to receive acalabrutinib on this clinical study. And again, acalabrutinib in this situation was continued until progression or intolerance. So overall, you will see that an improvement in the overall response rate, but as we know for this sort of disease entity, since it is incurable, overall response rate is a good start, but it is not the key. The key to this is progression-free survival, or hopefully overall survival in any of the treatments that we implement in this patient population. So we can see there is a progression-free survival benefit to bendamustine rituximab and acalabrutinib. And what we can also see, if we sort of censor sort of these events for COVID-19 at the time, which was prevalent, there is an improvement in the PFS benefit to addition of acalabrutinib in this patient population. But more importantly, again, there was no detriment to adding acalabrutinib to this patient population. So even with an indefinite use of acalabrutinib, we did not see these unexplained, unexpected deaths that were a problem with the SHINE clinical study. And as such, this did lead to the approval of the ECHO regimen for frontline patients with mantle cell lymphoma who are ineligible for autologous stem cell transplantation. So if we look at the older unfit situation now, I think the only thing we can safely say from all these studies is that we probably should not use R-CHOP in this patient population as a single agent. Again, multiple studies have shown that BR is better than R-CHOP in this patient population, and the more recent studies show that some of these novel treatments are also better than R-CHOP. So R-CHOP should probably stick to just large cell lymphoma and follicular lymphoma and sort of move out of the MCL space. And so this just summarizes sort of that discussion. Now, the bigger question is when we look at the older patient population with ECHO versus just using BR alone, again, that is a question we will struggle to answer because, again, sequentially, a lot of the data suggests that given a bendamustine rituximab and then following with a BTK inhibitor, relapse will give you the equivalent progression-free survival without the indefinite use of a BTK inhibitor. And some will argue there's some attrition in the frontline space, whether you will lose patients, specifically if they fail BR and they can't get to a BTK inhibitor. But that is likely a minority of the patients, so it does give you a little bit of sort of wiggle room to sort of make a decision based on some of your patient characteristics and patient sort of preference of whether you want to do a therapy, which will continue indefinitely, versus one that you can also stop at 6 months and then restart a BTK inhibitor later. So lastly, we'll dive into some novel combinations. Ideally, the phase 2 multi-center study of Bovin, this is specifically in patients with high-risk P53 mutations. So they enrolled 25 patients with evaluation with P53 mutation, which historically we know do very poorly with chemoimmunotherapy. So these patients were started with acalabrutinib and obinutuzumab, and thereafter around cycle 3 added venetoclax with a typical dose escalation from 20 to 400 milligrams. And thereafter, the patients could conceivably stop treatment after 24 cycles of therapy if they were in MRD undetectable state. So as you can see from this highly difficult to treat patient population, we see high response rates from this chemo-free treatment regimen, even though you do see 5 progressions and 4 deaths in this treatment population, but this still historically has been better than what we see with chemoimmunotherapy. And in this situation, with early follow-up, some of these responses do appear durable. We will wait for longer follow-up to sort of get a true sense of the durability of Bovin, but even with this early snippet, it does appear better than chemoimmunotherapy. And again, if we look at the progression-free survival and the overall survival, it did meet its primary endpoint with a PFS of 72% at 24 months and an overall survival of 75%. So this regimen, which can be started in a community setting, does appear very effective in this very difficult-to-treat patient population. And lastly, this is another novel combination, looking at acalabrutinib, venetoclax, and rituximab. This was a smaller study of 24 patients, specifically all patients with the mantle cell lymphoma, not specifically high-risk patients. As you can see, there was a high overall response rate in this patient population. Only events that we saw in this clinical trial were events related to COVID-19. And it does appear that the patients who were vaccinated had a much better response to the virus and did not succumb to the virus as those who were unvaccinated. But overall, this suggests that we can use these novel regimens outside of patients who have P53 mutations and still have durability of response. So as we move forward into some of these future clinical trials, a lot of these will be implementing these chemo-free regimens, and we will see how they compare to some of these other things, especially Triangle in younger patients and ECHO in the older patients who are ineligible for autologous stem cell transplantation. So with that, I'll conclude this treatment summary of frontline therapy for mantle cell lymphoma and where sort of BTK inhibitors fit and some of these novel regimens in mantle cell lymphoma. Thank you.
Thank you, Dr. Phillips. And let's go to our next case with Dr. Zafar.
The next patient, presented by Dr. Zafar, is an elderly woman acutely hospitalized with fulminant, widespread mantle cell lymphoma that required urgent inpatient treatment.
80-year-old patient, and she was referred to me from a primary care doctor for abnormal scan showing some lymphadenopathy. But, when I saw her in the clinic, she was extremely symptomatic, barely could walk into the clinic, huffing and puffing, short of breath. And she was okay like about maybe just 2 months ago, very functional and very, very sick. I decided to put her in the hospital and did some workup. She had extensive lymphadenopathy above and below the diaphragm, significant splenomegaly, pancytopenia. She had a bronchoscopy and biopsy, and also a bone marrow biopsy done, which showed and confirmed mantle cell lymphoma. Cas610 was more than 90%. We tried to do TP53 testing, wasn't done because of QNS specimen. But anyhow, she was so much symptomatic that we decided to treat her in the hospital with our mini CHOP initially. So I saw her in clinic after cycle 1, much better performance as overall. And we've been discussing about BTK inhibitors in her with or without rituximab. So we talked about Acala versus Zan.
Any questions about her case?
Yeah, I would like to know the faculty's approach in an elderly mantle cell. With or without TP53, what is their BTK of choice? Do they use the BTK plus VIN plus Abino in these situations? How is the tolerability been? I have not used the triplet yet. If they were to choose a BTK, do they prefer Acala? Do they prefer Zan? I know that, Acala has an indication.
Any other questions for the faculty?
Are they still recommending transplant after initial induction treatment for young patients with mantle cell or in patients who are otherwise healthy? What is their usually first-line approach with or without p53 mutations?
So great case. So Tycel, so this plays right into what you were talking about. This is an 80-year-old patient with very advanced disease, high Ki-67, unknown p53 mutation status because the testing didn't work. How would you approach this in your practice?
Yeah, in this sort of situation, ideally if we were to treat outside of a clinical trial setting, with such a high Ki-67, this would be somebody at which we would probably mutilate the echo regimen. Unfortunately, we would give it like an echo light. We would likely start the patient just with a BTK inhibitor to calm down the disease. Based on tolerance, at that point, we would add bendamustine rituximab, and we would only plan to probably use the acalabrutinib for a finite treatment period, just because of, obviously, the concern for indefinite use in any of these patients, because all of these drugs at some point will likely cause some adverse events that may not justify continuation as long as they're in remission. Now, if the patient had a p53 mutation, then I think it's hard to stop therapy in those patients, at which point you would likely consider more of an indefinite use because the risk of relapse is just much higher.
So BRA acalabrutinib. Dr. LaCasce?
I'd be a little bit worried. But I think this patient I would give chemo to up front. I think if you started a BTK inhibitor alone, it sounds very aggressive with a very high Ki-67 fraction. I think these people need some chemo. So I probably would start maybe with bendamustine alone, try to debulk a bit, wait to give the rituximab until you had a bit less disease around. And then depending on how they were doing, I might add a BTK inhibitor. But I think I would probably start with chemo first.
Yeah, but BR probably with Acala, but see how
maybe with Acala. I think that question that you just raised is the key one. Are we better off combining all three together or doing BR with maintenance rituximab and then saving the acalabrutinib for later? In this particular patient with such a high Ki-67 fraction, I suspect her disease is going to be very aggressive, and you may need to really throw a lot up front.
For an octogenarian with this presentation, I kind of like the BR with Acala, and I don't know that I'd necessarily stop that Acala if this patient was in response, given that this sounds like pretty aggressive disease biology. But, we have all these BTK inhibitors, Chris, multiple approved. Let's say this patient was much younger and eligible for the triangle trial. Do you use the triangle regimen in your practice? Do you omit the transplant with the triangle regimen? And do you use the ibrutinib, which was studied, or an alternate BTK inhibitor?
Yeah, I think as this group has heard previously from Neil Love programs, we very rarely give chemotherapy to patients with mantle cell lymphoma at MD Anderson. And so I think that the ECHO regimen would be an appropriate approach for a patient like this. We typically would, as you saw Michael Wong's study on acalabrutinib, venetoclax, and that would be the kind of regimen that we would think about for a patient like this. We now have a PVR upfront regimen where we're giving pirtobrutinib upfront to patients on clinical trial, and we would think about a non-chemotherapy-based regimen for a patient like this.
So, Dr. Brody, let's go to a younger patient, Josh, a patient in their early 50s with advanced stage symptomatic disease. What's your treatment of choice?
Yeah, we bastardize the triangle regimen and swap out the ibrutinib for something else, acalabrutinib, but to try to address the question of what's the right BTK, cal or xanu. There's no right one. We happen to use acala more. If we have a xanu trial, we put them on xanu. In our hearts, we feel like they're near to equivalent. We don't give them ibrutinib, even though that's what was studied in the triangle. The whole thing is mishmash because we say our CHOP is not the right thing, and yet we put it in the triangle and we get married to these regimens that we don't even think are maybe the best match. But because triangle had a great result, we give them CHOP DHAP for the younger patients. Sorry, I should have said that we do our very best to get NGS to find out if they're P53 mutated because then we would get them to probably a chemo-free bovin or a venetoclax CD20. P53 wild type, triangle, changing the ibrutinib for something else.
And one of the nice things about either triangle or echo is if you can't manage to get the BTK inhibitor, you can't get the P53 mutation status, you're still including a BTK.
You feel a little coverage.
Inhibitor for those patients. But let's say you knew about a P53 mutation. Are you going to a chemo-free regimen like bovin?
In real life, a lot of those patients, as this patient, start off in the hospital and we don't get them anything we'd like until we, get them a round of chemo. But then by the time, 21 days later when we find out or 28 days later when we find out about it, we will probably take them off the chemo, the P53 mutated. Yeah, we haven't done a lot of looking into the, VAF, the variant allele frequency of P53, but it probably does matter. And probably the high VAFs are absolutely in need of a chemo-free regimen focused on BTK, BCL2, but not well studied yet. The answer is we'll stop their chemo for P53 mutated.
Yeah, we've adopted bovin for our P53 mutated patients as well. Let's go to our next case with Dr. Morgenstein.
Dr. Morgenstein also has an elderly patient with mantle cell lymphoma whose management was complicated by psychosocial factors.
He's 83. He doesn't go to the doctor very often. Significant amount of alcohol abuse, which we've been dealing with. He had asymptomatic lymphadenopathy, which was biopsied. He was found to have mantle cell lymphoma. He received rituximab, bendamustine with perfect tolerance and nice response. He was placed on maintenance rituximab, which he did not really get a full course of it due to some intercurrent illness. He had a stroke. This was during the COVID period. He was actually very sick with COVID. So maintenance rituximab fell to the side. And then his lymphadenopathy has been slowly progressing, and he started to lose weight, and repeat imaging studies showed diffuse lymphadenopathy with involvement of the stomach, and who was recently biopsied and found to have recurrent mantle cell. So he just got started on acalabrutinib less than a month ago. My concern with him is he's not very compliant. He said he would do it, but I'm somewhat concerned. So the question is, in relapse mantle cell, particularly in the elderly population, what is the best BTK inhibitor? And now that we have 4 BTK inhibitors, how do we differentiate what to start based on side effect profile?
Any other questions you have in general about mantle cell you'd like to hear discussed?
I kind of got a little shocked by this, but there was some information about ibrutinib and sudden cardiac deaths. I had a patient who had CLL. He'd been on ibrutinib and he had died in his sleep, probably of a cardiac death. That's been weighing on me since I read that data.
Ann, do you start patients on ibrutinib anymore in 2025?
No, I do not. And for a patient like this, I particularly like zanubrutinib. It's easy to dose reduce in an elderly patient, and if you have someone you're worried about compliance, they get the headache from acalabrutinib, they may stop early. I've had very good luck with zanubrutinib in very elderly patients. I think the other question is not for this patient, but do you add in venetoclax to deepen the response and duration of remission? Not for this patient, but I think it's something to consider if the patient were younger and otherwise able to do the ramp up.
Tycel, assuming you're not giving ibrutinib, how are you choosing between acala and xanu?
Yeah, I guess it's whether I like Coke or Pepsi that day. But no, I think to Ann's point, I think if noncompliance is an issue, zanubrutinib is a little bit easier just because, again, if you dose reduce, it's still the same sort of situation versus acalabrutinib. You're basically going from one pill twice a day to one pill a day, and obviously that throws off the rhythm versus just dropping one pill from twice a day, or with zanubrutinib, they can take all the pills at once as well. So it gives you a little bit more flexibility with dosing. So I typically will pick zanubrutinib for that situation, but it's no rhyme or reason. Acalabrutinib is just as effective and safe.
And to the point of the question asker, this is a real phenomenon. These sudden cardiac death issues have shown up across ibrutinib studies, and that's part of why we've really shifted away from that first generation to our next generation BTK inhibitors that you're hearing about today. So let's move to our next module, and that's going to be on follicular lymphoma with Dr. Ann LaCasce.
Great, thank you very much. So we've already heard about several of these agents I'm going to discuss with Chris's talk in diffuse large B-cell lymphoma. So here I'm just showing the rationale for combining tafasitamab and lenalidomide. As you know, tafasitamab binds to CD19 and is engineered to have better ADCC and better phagocytosis. The lenalidomide also has direct effects on the malignant cells, but also enhances the immune response. So that was really the initial rationale for combining the two agents. So the InMind study was presented at ASH this year in the plenary session and randomized patients with follicular lymphoma, grades 1, 2, and 3A. Marginal zone was also included in the study, but not in this presentation. Patients got tafa-len plus rituximab versus placebo-len plus rituximab with a primary endpoint of progression-free survival. If you look at the baseline characteristics, this was a large study, and about 80% of patients met GELF criteria, meaning they had a significant burden of disease. And if you look here in terms of median prior lines of therapy, it was 1, though there were a significant number of patients who were more heavily pretreated. And about 30% of patients had POD24. We know that is associated with overall worse outcomes. And about 35 to 40% were refractory to their most recent line of therapy. So here's the progression-free survival, and you can see a nice separation in these curves with an improvement with the tafasitamab at 19 months compared to 16 months. And when they looked at subsets, high-risk subsets, including patients who were POD24 and those who were refractory to anti-CD20 antibodies, you can see that the progression-free survival benefit is seen in all of these groups. There was no difference in overall survival yet. And in terms of tolerability, you can see neutropenia, as might be expected, was the most common adverse event and was similar in its occurrence across both arms. Len discontinuations were similar, again, in both arms. And overall, this was relatively well tolerated. So if you think back to the original study that led to our use of lenalidomide plus rituximab compared to rituximab alone, the AUGMENT study, you might remember that the progression-free survival in that study was significantly higher. It was about 3 years. And here we're looking at 13 months. So I think it's important to kind of look at the patient populations. And what you can see in this InMind study is that it was a much higher risk patient population. Only 50% of the patients on AUGMENT had high tumor burden, and only 18% were refractory to their last line of therapy, and none had refractoriness to rituximab. So tazemetostat is a drug that's now been around a couple of years. It is an epigenetic modifier of EZH2, which is responsible and a key component of the germinal center reaction. And mutations in EZH2 lock B cells in the germinal center. About 20% of patients with follicular lymphoma will harbor an EZH2 gain-of-function mutation. In this study, both patients who were mutated and those who were wild type were included. And you can see here they were a relatively high-risk group of patients. About 70% GELF criteria, and about half of patients were refractory to their last line of treatment. About 20 to 30% were double refractory. And what you can see is that with regard to the overall response rate, for those patients who were mutated, it was about twice as high at 70% versus 35% in the wild-type population. Most of these responses were partial remissions. But interestingly, when you look at the progression-free survival, it looks relatively similar in these two groups with 13.8 versus 11.1 months which is interesting. So this analysis was then undertaken to try to match the patients with doing propensity matching to look at patient selection and see if that may have impacted the overall response rates. And you can see here when they matched for performance status, POD24 prior, stem cell transplant, double refractory, you can see here that 56 of the 99 patients were matched. And here the overall response rate in the wild type group came up to 50% versus 70%. So this may account for some of the difference we're seeing in this the initial study. So I think this is also very interesting. This data was recently published looking at EZH2 inhibition on T cell function. And you can see here that EZH2 inhibition prevents T cell exhaustion, promoting a memory phenotype and having other immune modulating effects. And we may see this, there are some trials that are starting looking at combining EZH2 inhibitors with CAR T, and I think one would wonder whether that might be something that would be of use in looking at bispecific antibody therapy. So the Rosewood study looked at zanubrutinib. This was an interesting study. Ibrutinib had been studied in follicular lymphoma previously, and the overall response rate was about 30%. And I think we all sort of assumed that targeting BTK in follicular lymphoma was not going to be a good treatment strategy. But this study took patients with relapsed follicular lymphoma and randomized them to obinutuzumab plus zanubrutinib or obinutuzumab alone in a 2-to-1 fashion. And you can see this, the patient characteristics here. About 30% had high LDH, and about half of patients were refractory to their last line of therapy. And you can see here the addition of zanubrutinib was associated with a significant improvement in overall response rate, 69 versus 46%, with a significantly higher CR rate of 57%. And when you look at the progression-free survival, these curves separate. So I think this was an interesting result. And if you look across all of in the forest plot here, looking at the high-risk patients, you can see that this benefit is seen across multiple high-risk groups. I also wanted to mention this study was a single-arm study of loncastuximab plus rituximab in patients with relapsed refractory follicular lymphoma. The schema here is a little bit complicated. This is how loncastuximab is administered with a higher dose for the first 2 cycles and then 75 micrograms per kilogram for the 3rd and 4th cycles. Patients who were responding then got additional cycles for maintenance. And then if they were in CR, they got maintenance rituximab. If they were in PR, they got additional loncastuximab and Rituxan. So most of these patients had only had one prior line of therapy, as you can see here. However, about 50% were refractory to their most recent line of treatment, and the median number of prior therapies, as I mentioned, was 1, but there were nearly 30% of patients who had had 3 to 6 prior lines of therapy. And this looked quite good. I think this was also a bit surprising with a 12-month progression-free survival of 95%, with a toxicity profile as we would expect from this agent. We heard about the GGT elevations, the skin toxicity, the edema. So this study, again, small, not a high-risk patient population, but may be an option for a patient who may not be able to receive a bispecific or has failed a bispecific. So what about more novel therapies? We heard a little bit about golcadomide, which is a first-in-class oral CELMoD. So this binds to cereblon and leads to ubiquitination of Ikaros and other proteins that are important in cell survival and immune stimulation. This is an allosteric binder, and you can see compared to lenalidomide really leads to very significant 100% degradation of these proteins. So there are a couple of ongoing clinical trials looking at golcadomide in combination with rituximab versus investigator choice in relapsed and refractory follicular lymphoma, and in the upfront setting in combination with rituximab. So we'll look forward to seeing the results of that study. And then, as was mentioned, the ROR1 antibody, which is expressed on a number of different subtypes of non-Hodgkin lymphoma. This is an antibody-drug conjugate to MMAE. And there are studies ongoing in diffuse large B-cell lymphoma, and also a study that is including indolent B-cell lymphoma. I honestly am not sure how often this ROR1 is expressed on indolent lymphomas. I haven't really seen that data, but this does appear to be a relatively well-tolerated agent. So more to come on this.
Terrific. Thank you, Dr. LaCasce. Let's go to our next presentation from Dr. Zafar.
The next patient, presented by Dr. Zafar, is a 68-year-old man with multiply treated relapsed follicular lymphoma, now with further disease progression, including biopsy-proven prostatic involvement. The patient was started on the bispecific mosunetuzumab.
He developed more bulky disease, much bigger prostatic mass. He was switched over to Mosun, and he's done tremendously well. Radiographically, he's responded really well. I just gave him his cycle 8 the other day. No tox, beautiful response. And the question is, of course, Mosun is time limited. And, does the faculty usually stop after a certain number of cycles, maybe cycle 8, cycle 9, reimage and stop it? Or if there's still some potential residual disease, do they continue until, cycle 17 or 16? I've sent him for a consult for CAR T. He's refused that. So in his situation, I'm going to reimage him probably next month. If he maintains the response, if he's near CR, should I stop Mosun altogether?
So, Josh, you're going to be talking to us in a few minutes about the bispecific antibodies. How do you dose mosunetuzumab in third-line and later follicular lymphoma?
Yeah, hopefully I'll be talking about it in a few minutes. I mean, it's getting late, so I'm getting a little tired, but I think I'll still be here. We do this as per recipe. If they're getting PRs up to 17 cycles, otherwise fewer. This it wasn't quite clear. This sounds like the patient was almost in a CR, or maybe the follow-up PET wasn't, or follow-up scan wasn't done yet. But yeah, we certainly don't continue, until progression or intolerance like we do with some other bispecifics. And with that recipe, we have fantastic results, and we have some precedent. This is, smaller data of resuming therapy if patients relapse at later time points, and if their, rebiopsy shows they haven't had antigen escape. So it's not that you're we tell our patients it's not that you're burning a bridge to stop therapy, because there is such a thing as retreatment, even though it's not very well studied.
Great. Yeah, so it is a fixed duration regimen, and I certainly adhere to that. And with bispecific antibodies, one of the concerns is the late infection risk from ongoing B-cell depletion. So 8 cycles for patients in a CR, 17 cycles for those patients with still a PR after 8 cycles. Ann, you mentioned you were talking about zanubrutinib, which I agree sort of was a surprising finding there. I guess 2 questions for you. One is where do you use the Rosewood regimen? And then a second, because it goes with an audience question that came in, is we talked a little bit about the risk of arrhythmias and sudden death with ibrutinib. What about the risk of ventricular arrhythmias with acalabrutinib and zanubrutinib? What do we know about that?
So we really aren't seeing that. The drugs, those 2 agents have obviously not been around as long as ibrutinib, but the rates of ventricular arrhythmias seem to be much, much lower, as is the risk of atrial fibrillation. With zanubrutinib, you can see a little bit more hypertension than I think with the other 2 agents. Honestly, I'm not sure where this will fit into, now that we have the bispecifics and mosunetuzumab, which is a very effective drug. We may see those moving up into the frontline setting, and maybe using obinutuzumab plus zanubrutinib in a relapse setting may be a good option for some patients. It's a relatively easy regimen. So, yeah, I think it's good to have it available, particularly for people who have failed a bispecific.
Yeah. And, as crowded as the landscape is, this is a chronic disease, and we often need new lines of therapy. And it is funny, there are these rarely reported ventricular arrhythmias, but certainly nothing that limits us from giving these drugs in clinical practice. Chris, with this landscape, and we heard about a lot of advances from Ann, in my practice, for my high tumor burden follicular, I typically give chemoimmunotherapy. In second line, I typically go to rituximab lenalidomide, and we just heard about the INMIND data. Should I be adding tafasitamab in my standard second line practice?
So I think that's very compelling data and really looks to show that you can add tafasitamab safely and that the progression-free survival is remarkably better. And so I think it's really a regimen that we'll be turning to increasingly. I do think, though, in relapsed follicular lymphoma, that's where the art of medicine really comes into play because there's so many different ways to treat patients and you need to tailor your treatments to the specific patient in front of you.
Tycel, one of the questions that comes up with CD19-directed therapies, and we alluded to this a little bit earlier, is the idea that maybe using the TAF earlier, could that somehow produce an antigen loss and limit our ability to give a CAR in the future? How much should we be thinking about that, particularly in a disease like follicular lymphoma?
That's a good question. I don't think it really comes up that much in FL unless you have a patient with a very aggressive form of follicular lymphoma. But for the general patient, they likely won't see CAR T in the near future anyway because of the effectiveness of the other treatments we have that precede CAR.
And, with these numerous options available, Tycel, one of our questions here is, when we heard from Ann about, probably Rosewood moving kind of being later in lines of therapy. As far as the TAFA-R-LEN, that's probably more in a second-line regimen and probably not directly competing with bispecific antibodies, would be my guess. Is that your impression as well?
The single agent is correct, but I think as we all know, there are numerous bispecific plus lenalidomide studies ongoing, and then the bispecifics may move into the frontline space as well with some of the other clinical trials. So I think it's an ever-evolving sort of landscape with follicular lymphoma as these drugs continue to move north.
And then, Ann, let me give to you by way of introducing the next session, which is where do drugs like mosunetuzumab and epcoritamab in your practice fit into follicular lymphoma?
So currently, we can get them in third line. So I think we're in that quandary, just as you've said. In the past, we were giving lenalidomide plus rituximab, not seeing the kind of responses that were reported in the original AUGMENT study. Now I think we kind of know why in comparing them. So I generally third line.
Great. I think that serves as a nice segue to moving to Dr. Brody and hearing about the role of bispecific antibodies across multiple lymphoma subtypes.
Jeremy, thank you. To the organizers, thank you so much. This is an exciting subject because, to editorialize right off the bat, bispecific antibodies are the most transformational class of therapies developed for non-Hodgkin's lymphomas ever. They are not the most potent. They are not, as universal, certainly yet as rituximab or some other gentle and well-tolerated therapies. But when I say transformational, it is my belief that they will affect the lives more significantly and of more patients than any other therapies we've ever developed. Editorialization. We're going to talk about CD20 by CD3 bispecifics because those are what are approved for non-Hodgkin's lymphomas, and we'll speak very briefly about some other novel approaches. So mosunetuzumab, as was just discussed, and put it here because first to be FDA approved for lymphomas. When you look at a waterfall plot that looks this beautiful, you don't have to say too much else. This is a highly effective therapy here for third line and later follicular lymphoma. And these remissions can be quite durable. So there on the Kaplan-Meier bottom left there, we see the duration of response. But again, as you see, most patients are having a response here, more than 85%. So this is most patients. And some of those responses can be quite durable. We have certainly patients here with 2- and 3-year remissions. And for those patients that get complete remissions, that was 60% of patients in this trial, extremely durable, and the median duration of complete remission not reached at the time of follow-up here, which was more than 3 years. So a lot of patients getting CRs and those patients having, on average, very durable remissions. And overall, the progression-free survival, just the thing we would describe to people as their overall likely outcomes when they get started on therapy, quite good. On average, PFS for these overall, some of them highly pretreated patients, a couple of years on average. And, of course, the overall survival, overall excellent for these folks. So this led to the FDA approval of Mosun now more than a couple of years ago. What year is this? What are we, 2025?
It's 2025,
Oh,
Dr.
my God, I'm
Brody,
late
yeah.
for something. Oh, boy. It's fine. We'll just do our best. This is overall a pretty well-tolerated therapy. We talk a lot about the cytokine release syndrome, but thankfully the vast majority of patients that have CRS, it is low grade. To be fair, there are probably even updates of these data now that we have improved our CRS prophylaxis and management a bit. But nonetheless, even in this first study, and this is the seminal data of intravenous mosunetuzumab, we have more recent data of sub-Q mosunetuzumab, not yet FDA approved, so this is what is available in the pharmacy today. And again, most of the CRS is low grade. I'm not going to go into the timing in much detail, but these are almost entirely contained to the first few doses of therapy. And the only other side effect adverse event that I'll mention at all is the neutropenia, because when we got started with these therapies, a lot of these patients came in moderately neutropenic, and I was unsure, maybe I think many of us were, if the neutropenia was real or just a product of baseline bad CBCs. But I think with repeated data and across all these platforms, we see that there is some neutropenia. It is mostly not too deep. I mean, there are some grade 4s here, but these are not chemo-like neutropenias. And again, I'll editorialize a bit. Like rituximab, which has this we call delayed onset neutropenia. Again, this is not contained in this data here, but I'll just comment that we see some of that as well, some delayed onset neutropenia as well. So the timing is not chemo-like timing for this moderate neutropenia. And to the other FDA-approved bispecific for follicular lymphoma, epcoritamab, stemming from the seminal trial here, or the part of the EPCOR NHL-1 trial. Again, extremely high response rates and CR rates. CR rates in this study, 63%, very comparable to mosunetuzumab. I would have to say overall equitable between the two. And you see that those patients that had complete remissions, which was, again, many of them, almost two-thirds of them, they appear to be quite durable. The follow-up of this study is not too far along yet, but so far pretty durable remissions. And just looking at subgroups overall, the therapy was effective across all groups. The highest FLIPI patients had a little bit less benefit using CR rate, and patients who were refractory to their prior therapy, a little less benefit. But still, even those patients, for example, refractory to prior therapy, still had a 50% CR rate. So that is nearly incomparable for what is overall a pretty well-tolerated therapy. And again, more similar than different to the mosunetuzumab data I showed a moment ago. And just to focus on the CRS, again, here, the vast majority, almost all of it, we call grade 1, 2. Again, I think this maybe sometimes gets more attention than it warrants. Almost all of us in the room got grade 1 CRS with our COVID shots. Are we still allowed to mention COVID? Okay.
Yeah, this is a safe space,
okay.
Dr. Brody.
So it's grade 1 CRS, not too bad. Tylenol, ibuprofen, acetaminophen, ibuprofen, and patients do well. Overall, very well tolerated. I do have to emphasize here that the label for epcoritamab for follicular lymphoma uses a triple step-up dosing as opposed to the double step-up dosing that is FDA approved for DLBCL. So it has an intermediate dose, 0.16, 0.8, 3 milligrams for follicular lymphoma, and then full dose, 48 milligrams. Overall, well tolerated, and I think similar. These, as was mentioned by everyone here tonight, are moving both into earlier lines of therapy and, of course, into many possible combinations. Couldn't possibly show all of the ongoing and upcoming trials. Every agent you've ever heard of is being combined with bispecifics, I think justifiably so. So I'll just show a couple of examples for some of maybe the most obvious combinations. So this is R squared plus epcoritamab phase 2 for follicular lymphoma as frontline therapy, small study, 41 patients, but overall with a response rate of 95%, CR rate of 85%, and fairly early, but you can see that those remissions there, both from the swimmer's plot and from this Kaplan-Meier curve, overall so far, pretty durable remissions. So this is evolved into a randomized phase 3 trial, which is ongoing, and we will hopefully see some data from that in near to come future meetings. And a very similar, but I picked this trial. There are a number of, again, R squared plus bispecific trials in front line and in second line, but I picked this one because it's a bit interesting and championed by Adam Maslewski at Brown, where it's our risk-adapted approach, giving mosunetuzumab monotherapy for the patients that have CRs, continuing their monotherapy for the standard 8 cycles here in the frontline setting, and for those with PRs or stable disease, adding in lenalidomide at that time, and for those with progression coming off study. And I think this is an elegant, very personalized approach, which is what we are aspiring for, I think, to give the right therapy to the right patients. As was said, follicular lymphoma more as much an art as a science, so there's so much heterogeneity. Why not give the right therapy to the right patient? Overall, the safety of the regimen was comparable, certainly to the mosunetuzumab. Sorry, I should have emphasized that this is now migrating to the subcutaneous mosunetuzumab, so now we see the adverse event of injection site reactions, but almost completely low grade. We see a lot of these. The patients note them but don't really complain about them. And I'm from New York, and there's a lot of complaining, so that still means it must be a pretty low grade. And overall, the efficacy here has been fantastic. CRs in a great majority of follicular lymphoma patients, even a bit more in marginal zone, but as I mentioned, a very small trial so far. But I think very promising data and, and a bit innovative to try to risk-adapt therapy or augment for patients with early suboptimal responses. So pretty cool that they've been able to champion this approach. And going to DLBCL, as was alluded to, the seminal trials for the FDA approvals of, we'll mention both epcoritamab and glofitamab, 150 patient, just above 150 patient trials. And I will just comment that these agents have been really, in this setting, more similar than different. In both excellent single-arm trials, 150 plus patients, CR rates of about 39% across platforms. So this is the epcoritamab, the waterfall plot, and progression-free survival. Again, these were, in many cases, highly pretreated patients. About a third of these patients were CAR T relapsed, but I'll just comment there, more than 90 to 100 days CAR T relapse, rapid relapsers were not included in these studies. And overall, for those two-thirds of patients that had remissions, some of those remissions extremely durable. Again, the data is a bit early in follow-up so far. The comparable trial with glofitamab, again, you see here on the left, complete remission rate of 39%. Overall, more similar than different to the epcoritamab study. And again, patients that had CRs, many of them extremely durable. This data a bit more mature than what I just showed you before, but at 2 years, the majority of CR patients with this monotherapy still in remission. So these are transformational therapies for low-grade and aggressive lymphomas. And I'm going to mention the STARGLOW trial. It is not at all awkward for me to describe this study when the first author of the paper is sitting here to my left and always ready to pounce if I were to say anything that wasn't exactly right. So I'll just do my best. This is a critical trial and an unprecedented result in that certainly there was no precedent of demonstrating overall survival benefits using bispecific antibodies. And I would just say in the logical way, combining them with chemotherapy because they have non-overlapping toxicities. So, we don't treat DLBCL with C or H or O or P. We treat it with CHOP, maybe not mantle cell, but still many DLBCL patients, even if we take out the O. So combination is the basis of medical oncology. So this is the logical trial, and this beautifully executed randomized trial of 270 patients showing a large progression-free survival benefit for the addition of GlowFit to GemOx compared to our GemOx as the comparator, and a significant overall survival benefit at the early described follow-up here from the Lancet 8 months ago now. And I'm going to editorialize a bit here that this study has been in the news recently for how well appreciated this study is. I'm going to comment more on it in a bit, but I think we could substantiate it a bit by also including mention of this lesser phase 2 non-randomized trial of epcoritamab, the other FDA-approved bispecific in this setting, combined with a similar backbone. The GemOx was administered a bit differently, Q2 instead of Q3, otherwise comparable 8 cycles. And, a bit small there, but you can see overall, let me just see if I can, overall, we had a very similar complete remission rate of 60% here. The differences between the trials on the left and the right, although they're similar, there were some. The majority of 60-40 of the STARGLO trial, second line versus later lines, 40-60, the flipped ratio in the EPCOR GEMOX trial. And overall, the results were not identical, but they were more similar than different. A very similar complete remission rate in the EPCOR GEMOX trial of 60%. Again, in many of these highly refractory to prior therapy and refractory to all prior therapies in this group. I won't go through all the subgroup analysis, but another difference is that the STARGLO trial had about half of the patients treated in Asia, Australia. I'm not quite sure why we lumped those two continents together, but many of the patients were non-Western, whereas the majority of patients in the EPCOR GEMOX trial were treated in Western countries, if that were to make a significant difference. And despite that difference, very similar results overall in the two studies.
With your editorialization, I'll remind you we've got 1 minute left for you, Dr. Brody.
Thank God, because I was reading. So the subgroup analysis, I will not go into great detail, but to point out that there were some differences seen in the geography of where we treated the patients, but this is just absolutely insane to even care about because there were not enough patients treated in North America to make a comment to make a statistically meaningful comment about whether those patients did better or worse overall. So I'm going to acknowledge it and then poo-poo it. This was overall an incredibly important trial for our patients. And then moving quickly to an update that Dr. Abramson was kind enough to share with me. The punchline is, here with later follow-up, the results, I will just say, are comparably excellent. No diminution in the benefit of overall survival or progression-free survival. I'm going to make a very quick comment about the use of glofitamab. It was already alluded to by Tycel. Amongst the most potent therapies ever described for mantle cell lymphoma in later lines of disease. You know, we're not going to compare it to CAR T cells. Maybe that will get commented on in a moment. But overall, very well effective therapy, and the tolerance in mantle cell lymphoma is a bit worse. The CRS is more high grade. These patients do have more extranodal disease, probably greater disease burden overall, and that is being addressed in maybe how we can optimize the CRS prophylaxis in an ongoing arm of this trial. And we have at least one example here of bispecifics beyond CD20. I'll mention this AstraZeneca CD19 by CD3 bispecific, and I won't say much about it other than point out the results have been excellent so far, very high response rates and pretty good durability in both low-grade follicular and aggressive DLBCL. So we're looking forward to getting more data with this novel bispecific. And I'm going to defer to Dr. Buffalino.
Thank you, Dr. Brody. We'll cut you some slack because you've acknowledged you're only A&O times 2 this evening. And so let's go to our next case with Dr. Buffalino.
The next patient, presented by Dr. Buffalino, was evaluated for a neck mass that on biopsy was diffuse large B-cell lymphoma.
This is a 73-year-old male. He has a history of AFib and TIAs, and he's on Coumadin and aspirin. He also has a seizure history, and he's on Keppra. Completed 6 total of R-CHOP. But his end of PET scan showed that the left neck mass was enlarging, and there was increase in SUV uptake. So I sent him for another neck biopsy, which confirmed diffuse large B-cell lymphoma. So this was a primary refractory disease, so had progressed sort of on the tail end of therapy. I referred him for CAR T-cell evaluation at that time, and where he was evaluated, deemed he was not an appropriate candidate due to his seizure history, his neurologic history. And they recommended to proceed with bispecific T-cell engager therapy. So at this point, I would just pose the question of, which of the drugs to choose in this category and why. The other question I would have is, if this patient does progress on BiTE therapy, is there any role in sequencing the BiTEs as they all sort of have the same target of CD20? Is there any role in that? And do we have any emerging data in that situation?
What's the patient's current situation?
I gave him epcoritamab, and he's been on that for over a year.
Wow.
And on PET-CT, he is in a CR.
Wow.
He's doing wonderful.
How did he tolerate the treatment?
Very well. Minimal toxicity. He had like a grade 2 CRS in the beginning, but now he's tolerating it very, very well.
Is he going to get the EBCO indefinitely or for a specific duration?
Yeah, so that's another really good question. The epcoritamab was sort of studied as an indefinite therapy or as long as people were tolerating and responding. There are obviously other BiTE therapies that have more of a definitive timeline, but for this gentleman, I've kept him on therapy.
So, Tycel, you've done a lot of work on bispecifics, and we have a bit of an embarrassment of riches in both large cell and follicular lymphoma. We've got multiple products. There are differences, and it gets to the heart of this case. In relapsed large cell lymphoma, in this 73-year-old, how do you weigh epcoritamab and glofitamab?
Very good question. Given the similar efficacy and similar long-term response at this point, it's very hard-pressed to put a person on EPCO versus Glofit, because with Glofit having a more finite treatment regimen. And so in that situation, a lot of the patients will be put on glofitamab just because there's a stop date.
Because it's time limited. Dr. Flowers, maybe any response that you have to that, think about time limited versus continuous, and then how you might approach a similar question in follicular lymphoma where you're choosing between EPCO and Mosun.
Yeah, and I think the real question here is, do you think that you can give this patient curative therapy? And curative therapy can only be time limited. And so if you're considering that in this particular situation, I would consider a curative approach for this particular patient with a time limited therapy. That being said, this is a particular patient as described, that may not be the goal of therapy at this point, is to give curative therapy. And so giving something that might be not only indefinite therapy, but maybe also a therapy that gives you time to be able to give something else later on after you've controlled the disease a little bit later on. In follicular lymphoma, I think, in general, we're talking about not giving curative therapy to patients from the start. But all of us know that there are patients with follicular lymphoma that we consider to be cured. When I have that conversation with patients, what I tell the patient is that we can't tell you when you're cured, but there definitely are patients out there that we know that we've cured of their follicular lymphoma because they die of something else. But that's the only time when we can say that. And so the bispecifics really have a different role and a different question there, and that's really prolonging progression-free survival in a way that's providing a meaningful benefit to the patient.
And Ann, question comes up about sequencing. If somebody had progressed on one of the CD20 bispecifics, would you go back to a bispecific?
No, I don't think we have any data that that's going to be a good strategy. And maybe if there was something intervening, but I think for large cell lymphoma, that's a very unusual situation.
What about, and I'll go to Dr. Brody with this, Josh, if you've got a patient who got a time-limited bispecific, whether it's large cell or follicular, and then they go into remission and they progress 6 months, a year later, is that a scenario you might consider retreatment?
There is a precedent of that, and they've seen, some efficacy. It's just the data's small, so hard to say to a patient how effective this is. Let's acknowledge, as you hinted, maybe was said a few times, that the mechanism of relapse that we've seen more than anything in bispecifics is antigen escape. It seems to be much more common than in CAR T-cell therapy, and we have studies showing 38% CD20 loss, 50% CD20 loss, a small study with 80% CD20 loss. So, a 6-month relapser like you described, you'd be certainly worried about that, and biopsy would be absolutely necessary. And if they were CD20 positive, such a thing exists. We would really, of course, love to get that patient on a trial of a mechanistically distinct therapy.
And Chris, you've got a patient on a continuous epcoritamab schedule. When would you consider stopping that epcoritamab?
Yeah, and so I think, the situations are very different for diffuse large B-cell lymphoma and follicular lymphoma. In this particular patient with diffuse large B-cell lymphoma, the ideal situation would be to see that patient is MRD negative. We actually do not have an available MRD testing in this situation to 10 to the negative 6. This was a really nice presentation that happened at this year's ASCO meeting that provides us a little bit more data about that approach. That being said, with available technologies, you'd want to see that patient to be PET negative and with stable PET negative disease, and then feel confident with the patient that they're comfortable stopping therapy.
Great. Yeah, and certainly accruing toxicities, infections need to be taken very seriously. And thinking about patients on continuous therapy, about immunoglobulin levels and risk of serious and recurrent infections. Great. Why don't we go to our next case, and that will be from Dr. Chen.
The next case, presented by Dr. Chen, was an 86-year-old man who received BR in 2017 for stage 4 follicular lymphoma, followed by tazemetostat for his EZH2 positive disease and received this for 3 years, followed 1 year ago with disease progression and treated with mosunetuzumab, which resulted in a complete remission and discontinuation of the bispecific.
This is a very nice 86-year-old male with follicular lymphoma. Some of my questions to the faculty would be the best way of AE management of the mosunetuzumab in terms of the AE management for CRS, or is there any concern for ICANS? And also for him, the choice of CAR T versus bispecifics. Now, if he has progression of the disease, would you resume mosunetuzumab at this point or change to something else? He's doing really well.
Wow, what a case. Did he have any tolerabilities, any CRS, any ICANS?
Yeah, he did. So usually mosunetuzumab, you could do everything as outpatient, but because of his age, I did admit him for the first couple of doses. And he had a mild CRS, which resolved with dexamethasone alone, and he did not need TOCI.
So you managed him or primarily, or you were working with the tertiary care center?
We got a recommendation to start the mosunetuzumab from tertiary care center, but he did not want to travel, with his age, and so we managed him locally.
Wow.
He really did not want to travel. His support system were all local, so he really just did not want to travel.
Yeah, no, but, we've been asking investigators, particularly about mosunetuzumab and in follicular lymphoma, do you think oncologists can start this without having to go to tertiary center first? And they're all like, I think so, if not now, very soon. Yeah, I've heard them say they give steroids to take home to those patients. So they get a fever, they tell them to take it.
We actually did that. We prescribed him steroid
Really?
to take home. He called, with a fever. So we told him to take it, and he took it at home. And he was fine, so we kept a very close watch on him.
So fascinating case. And a lot of these questions are going to come up, Ann, about sequencing bispecifics and CAR T-cell therapy. So let's start with this patient, follicular lymphoma. How do you think about selecting those two novel immunotherapy approaches?
Yeah, I think in a patient like this, the outcomes with the bispecifics are really outstanding, as we just saw. So I would reserve CAR T for more aggressive, maybe younger patients who are, progressing rapidly or at POD24, and I would use, a bispecific in a patient like this. I think mosunetuzumab is a perfect choice. I think it is the easiest to give. I think most patients have grade 1 CRS. We treat people as an outpatient generally, and I think if with good education and algorithms, there's this great paper in Blood that outlines exactly how to manage these. When you see the CRS, I would really recommend that paper. And these patients do great in general.
Yeah, the sequencing issue can be different by histology. In follicular lymphoma, I'm usually reaching for a bispecific before a CAR. It's not per se a curable disease. It's easier logistically. Makes me think about that last case, the large cell lymphoma patient. And I actually wonder, Ann, if we come back to that, is a seizure disorder a reason why you couldn't give a CAR T-cell?
I don't think so. We put people on Keppra and we worry about seizure, but I can't think of the last person I heard of at our center who actually had a seizure. It's not a typical toxicity. And, I think that patient was only in their 70s. I think, lysacaptogene would have been a good option for that patient. It's sort of one and done. Yeah.
Yeah. I think in a patient like that, I'd avoid something like Axi-cell, which has a higher risk of neurotoxicity, have them on anti-epileptic prophylaxis, but I wouldn't necessarily consider it a contraindication. Dr. Flowers?
Yeah, this could have been a patient that was treated early on in the CAR T-cell era where we weren't routinely giving prophylaxis for seizure disorder, and that could have been a concern, so I can understand that. But now, as Ann said, in the modern era with seizure prophylaxis, we almost never see that.
Okay. Let's move to our last module, and we're already hinting at this, which is CAR T-cell therapy across lymphomas, and we're going to start with diffuse large B-cell lymphoma and then talk about other histologies as well. So the good news about the second-line trials of CAR T-cell therapy in DLBCL is you already heard about them from Chris. And you know that there were 3 trials, similar designs, all in either primary refractory or early relapse, defined as within 12 months of initial chemoimmunotherapy. And you heard from Chris at the ZUMA-7 trial and the TRANSFORM trial of Axi-cell and liso-cel, respectively, were both positive. The third trial we haven't mentioned was the Belinda trial looking at Tysogen leclusal. That was an entirely negative study. And you saw these data showing definitively that for patients with primary refractory or early relapse disease, we see a superior complete response rate, event-free, progression-free, and trending towards overall survival for liso-cel with a and axi-cel. And in this study is the axi-cel study, which at 4 years of follow-up does show a statistically significant overall survival favoring axi-cel over standard of care. The liso-cel study was transformed, also superior CR rate, event-free, progression-free survival, an 11% non-statistical improvement in overall survival, but this was impacted by the fact that this study had built-in crossover, and so those patients immediately received liso-cel at progression, which wasn't included in the axi-cel study. Lower rates of CRS and neurotoxicity with liso-cel compared to axi-cel, which might be a consideration, such as that patient we talked about moments ago. But importantly, both of these studies showed that the CAR T-cells also improved quality of life by patient-reported outcomes compared to the historic transplant approach, which I would definitively say just doesn't have a role today for primary refractory and early relapsed patients. Now, I mentioned the Belinda trial was negative. Here's the data proving that to you. I will say that there are probably many reasons for this. Some were due to the design of the study, which had some difficult elements to the design, and others are probably related to the product Tycel itself. But suffice to say, Tycel does not have a role in the second-line management, though it is a generally well-tolerated CAR T-cell product. But where we started using these CAR T-cells is in the third-line and later setting. And so if a patient doesn't receive CAR in the second line, then we should think about CAR T-cells in the third-line setting. And we know that all three of the products I've just mentioned, axi-cel, liso-cel, and Tycel, have shown very encouraging results in third-line or later patients. And all of these studies had a median of 3 prior lines of therapy, which means these were patients who were mostly treated in the fourth-line or later setting. We see complete response rates, about 54% for both axi-cel and liso-cel, and a 2-year PFS of just about 40% for axi-cel and liso-cel. Those numbers are a little bit better than the third-line data and later with Tycel, again suggesting there might be something to that product that's just less effective than these other 2 products that we now use more commonly. We also see some differences in the toxicity profile, again reflecting higher rates of CRS and neurotoxicity with axi-cel compared to liso-cel and Tycel, but I have to emphasize we've gotten so much better at treating CRS and neurotoxicity, particularly intervening early at this, and that can help blunt the progression to high-grade CRS when we intervene, say, in a grade 1 CRS in an axi-cel patient can often prevent further progression. But it's now notable that we have 5-year data for both ZUMA-1 and Transcend for really durable long-term outcomes with axi-cel and liso-cel in patients with third-line and later DLBCL. And look at these disease-specific survival curves. Just more than half of patients have not died of lymphoma. These were patients with primarily chemo-refractory disease after 2 or more lines of therapy, and about 40% of these patients remain alive 5 years later. This is a dramatic change to the natural history of DLBCL, which previously, before CAR T-cells, had a life expectancy of 6 months or less with multiply relapsed and refractory disease. And here, the majority of patients have not died of lymphoma at 5 years, highlighting the game-changing nature and highlighting that the plateau on these curves really do denote curative potential of these regimens in large cell lymphoma. But we do need to be thinking about late toxicities, and we're seeing more and more attention to this, both with CAR T-cells and with bispecific antibodies. We do see some prolonged B-cell depletion, prolonged hypogammaglobulinemia, and these are heavily pretreated patients who get Flu-Cy lymphodepletion and can have prolonged CD4 lymphopenia as well. So thinking, though, this is a one-and-done treatment approach, the toxicities and risk for infections can be quite prolonged. We do see about a third of patients with prolonged cytopenias, but most of these are resolving after day 90. But if we look at infections, this is data from the Juliet trial, you can see that, that even after 1 year 40% of patients have reported infections on this study, 13% grade 3, and 3%, apologize for the typo, grade 4. So a small risk, but not insignificant risk of high-grade infections even a year later. What do I do about that in my practice? Well, one thing is I continue pneumocystis and antiviral prophylaxis in these patients. Some people like to do this empirically for a year. I personally have seen CD4 counts never recover in these patients, and I, in my practice, check CD4 counts to determine when I'm going to stop prophylaxis. In any patient with recurrent or severe infections, checking an IgG level and repleting those patients if their level is less than 400. Secondary malignancies must talked about, although I have to say in the third line or later setting, these are mostly in malignancies that you would expect to see in an older, heavily pretreated population. Here you see a late secondary malignancy risk of 8%. We saw the same thing in the Liza-cel Transcend study, and I think this is not different from what you would expect in the general population of heavily pretreated large cell lymphoma. Turning to follicular lymphoma, you heard beautifully about this disease. We now have 3 different CAR T cells with regulatory approval in the United States for relapse refractory follicular lymphoma: Liza-cel, Tycel, and Axi-cel. All of these were studied in heavily pretreated patients. The most heavily pretreated were in the Tycel Ilara study with a median of 4 prior lines of therapy, and those patients also had a higher rate of chemo-refractory disease. Important to keep that in mind when we look at the results, whereas the Liza-cel and Axi-cel studies were fairly similar. 2/3 of patients were chemo-refractory and a median of 3 prior lines of therapy. The CR rates are extraordinarily high. 94% for Liza-cel, 69% for Tycel, 79% for Axi-cel, and these responses are durable. With progression-free survival for both Tycel and Axi-cel, half of patients remain progression-free 5 years after their one-time CAR T-cell infusion. These can be quite durable. We have shorter follow-up on Liza-cel, but 3/4 of patients remain progression-free at 2 years. So these are durable remissions in these patients, and that might be preferable to some, but you heard about bispecific antibodies, which are a potentially less intensive way and a way that doesn't require lymphodepleting chemotherapy to induce remissions in a disease we don't typically consider curative. If we look at third line or later CAR T-cell and look at KM curves, this reflects the excellent progression-free survival that I showed you moments ago. Again, I think validating durable remissions. I would suggest I'm not convinced we're seeing true plateaus. There are a lot of sensor bars toward the end, and I think the longer we watch these patients, this is follicular lymphoma, we're likely to see some late recurrences. But we have some interesting data, particularly from the Axi-cel study, that retreatment for patients who'd relapse years later could actually be quite effective, and that might be an appealing strategy, although with bispecifics available, we'll probably be sequencing these drugs. And then turning to mantle cell lymphoma, we have 2 now FDA-approved CAR T-cells for multiply relapsed mantle cell lymphoma. Both of these were studied in patients who'd already received and progressed after a covalent BTK inhibitor, and these were predominantly patients in the third line or later setting. Brexucel induces a CR rate of 67% with a median PFS of 25 months. Liza-cel, a CR rate of 72%, a median PFS of 12 months. Those numbers look different. It's not clear to me whether that's actually a difference with the products or whether it's a difference in the patient populations. There is a real-world European study of Brexucel where the median PFS was 12 months. So I think these are still relatively small studies, and I consider these generally analogous treatments. I will say that the risk of CRS and neurotox is much higher with Brexucel than Liza-cel. Particularly the neurotoxicity with Brexucel can be quite challenging to manage, and I do think very seriously about toxicity and tend to favor Liza-cel, particularly in a patient who might be at higher risk of toxicity or at higher risk of not tolerating that toxicity, ending up in rehab, etc. And then finally, just one word about marginal zone lymphoma, and that word comes from everyone's favorite, a corporate press release. This is a press release that was published on February 10th, 2025, announcing that the marginal zone lymphoma cohort of the Transcend follicular study of liso-cel has met its primary endpoint for a significant overall response rate in patients with relapsed refractory marginal zone lymphoma, as well as meeting its secondary endpoint of complete response rate. The press release tells us that liso-cel showed durable remissions with a favorable safety profile, and this is by way of teasing that at the upcoming ICML meeting in June, we are going to see data in the marginal zone lymphoma cohort for the first time, so stay tuned for that. So I think we're seeing that CAR T cells are really producing transformative efficacy across the B-cell lymphoma spectrum. And the challenge now, and I think the topic for the panel, is how we're sequencing these drugs with all the other new therapies we have, like bispecifics and other targeted therapies. And to lead us in that direction, we'll go to a case from Dr. Brenner.
The next case, presented by Dr. Brenner, brings up the critical issue of sequencing of CAR T and bispecifics in older patients.
This is a patient who's 81 who presented with a diffuse large B-cell lymphoma, non-general center subtype, and just recently relapsed with bilateral large lung masses with a biopsy confirming recurrent diffuse large B-cell lymphoma. He currently has moderate symptoms with cough and shortness of breath and an ECOG performance score of 2. And this is his PET scan showing significant pulmonary involvement as well as some lymph node involvement by his recurrent diffuse large B-cell lymphoma. The question I have for clinical investigators is, how do we differentiate between considering CAR T therapy versus bispecific or another type of therapy, particularly in elderly patients like this who have borderline functional status, quite symptomatic, and may not have the time to get their CAR T therapy? Can we use other agents such as bispecifics? And what is the role of bridging chemotherapy? And if we do use bridging chemotherapy, what agents should we use? He's very borderline for, I think, even just referral to an academic center. So he's still contemplating whether he even wants to be referred. He doesn't have a lot of medical comorbidities. But, the problem is, these elderly patients, you still got to refer them to, for me, a center, which is still kind of at least an hour away. It takes a while to get in. It's kind of tricky.
An 81-year-old patient, refractory large cell lymphoma, highly symptomatic. I think Dr. Brenner brought up some of the key challenges we face.
Yeah, I think this is a patient I would probably take to Glofit Gemox. You can get it right away. He has a lot of disease. I think he is at very high risk of having significant progression before you could get him to liso-cel. Obviously, he's not a candidate for axi-cel. And then the question of bridging, he would need bridging. I think this is a patient who would probably do well with a Starglow type approach. I have a very similar patient in my practice at 87, and we had exactly the same situation, and he's done very well.
Chris, maybe if we had a little less urgency here and the patient was willing to hear out CAR T cells, what are your bridging approaches? This patient has a non-GCB large cell.
Yeah, and maybe I'll start with age is really in the eye of the beholder and going back and forth with the patient. Last time I was on our CAR T inpatient service, I think we had 4 80-year-olds on the service at the same time. So the same 80-year-old person might be appropriate for a bispecific antibody in one setting, and another setting might be specific for CAR T. When I'm trying to go for a CD19 CAR T, I want to use a regimen that is not CD19 focused in that setting and want to avoid bendamustine. And so polatuzumab has been one of our bridging therapies that has been a go-to. I think one of the things exciting about diffuse large B-cell lymphoma now is that we now have multiple curative regimens in the first-line setting. We have multiple curative regimens that you talked about in the second-line setting, and we have multiple curative regimens in the third-line setting. And we might see in the coming years that we have multiple curative regimens in the fourth-line setting as well. And so I think for a patient where you're thinking about a curative option, you need to fully evaluate that before you think about things that are more palliative.
Tycel, let me ask a question about bridging. Where does radiation fit in?
It's actually a very effective strategy. There's plenty of data that supports it. It actually may enhance the CAR T-cell product. So if you can radiate, then obviously that's something you can use as a bridging therapy versus systemic therapy.
And then, Josh, let's go to you in the last question here and think about outside of large cell lymphoma, we talked a little bit about follicular earlier. We haven't really talked about mantle cell. You've got a patient who got treated with the triangle regimen up front. They got a BTK inhibitor. They're now progressing a year after that. How are you going to approach this patient, and where do CAR T cells fit in?
Yeah, you actually, I think, said on your last or second last slide that just semantics to separate debulking and bridging therapy. Debulking prior to the pheresis and bridging, we'd say, after the pheresis. And trying to avoid, especially some agents during that debulking phase, things that might harm the pheresis product. Pirtobrutinib you put on your list as a very easy to use debulking or bridging therapy for mantle cell lymphoma, and that's something that I've even in the last couple of weeks had to do quickly available, get them pheresed, and then get them there. It depends on the response. Then you have these people get debulking and bridging therapies, have an amazing response. They will hold that CAR T product for an extended period of time. So it depends on the patient. An 81-year-old doing amazing on their bridging Pirto might stay on Pirtobrutinib for a while. So yeah, we're lucky to have a lot of good agents that can get us to the pheresis and then to the CAR T cell.
Yeah, I often use Pirto as a bridge to Brexacel by way of trying to maximize remission and go in at a lower tumor burden state to minimize toxicity. Let's go to our next case from Dr. Bacow.
The final case is presented by Dr. Bacow, a 76-year-old man with a 14-year history of recurrent follicular lymphoma that transformed to diffuse large B-cell lymphoma, treated initially with R-CHOP, which caused a brief response followed by progression.
In October of 2023, he developed internal mammary lymph nodes that biopsy showed relapsed diffuse large B-cell lymphoma. He began polatuzumab and rituximab as a bridge to CAR T-cell therapy, and then ultimately underwent leukapheresis and was infused liso-cel in December of 2023. In January 2024, he had a PET-CT that shows a complete remission, and he remains in a complete remission at this time. So some of my questions are, as a community oncologist that refers patients out for CAR T-cell lymphoma, what types of things should I be looking for in the community on how to manage these patients? Should I be looking routinely for hypogammaglobulinemia and infusing IVIG if they have recurrent infections or low immunoglobulin levels? How often should I be seeing them? How often should I be checking their CBC and neutrophils and giving them GCSF? And then even more importantly, I see a lot is, how do I vaccinate these patients? A lot of these patients need vaccinations again. Are there NCCN guidelines for patients that have received CD19 CAR T-cell therapy on how to give these patients vaccines? If you saw this patient today who had refractory diffuse large B-cell lymphoma, how would you approach this patient? Would you proceed immediately with CAR T-cell therapy? In a patient like this who is somewhat hesitant to proceed with certain therapies, would you offer him bispecific antibodies? Would you even consider talking about an autologous stem cell transplant?
So primary refractory DLBCL, this patient's in a durable remission after liso-cel, and anything you would do differently?
Absolutely not. That was a great outcome.
And I think Dr. Now I'm blanking on his name.
Bacow.
Dr. Bacow brought up this key point we alluded to earlier, monitoring for late toxicities. Tycel, what's your general approach to monitoring these folks long term? How do you think about vaccines, immunoglobulins, prophylaxis? All in 1 minute.
Yes, I think everything you brought up was good points. Obviously, you'll follow these values, especially if the patient hasn't recovered any of these values within a short period of time. Obviously, we'll continue with longer follow-up. And again, with the vaccination important for these patients, given the patient's age and where they are in a community setting, that may not be a bad idea, especially for older patients, to prevent some viral infections and things of that nature.
And I just think a key point is it's so critically important that folks at academic centers who are administering CAR T cells are partnering hand in hand with our colleagues who manage these patients in the community. This is a team effort, and these patients need long-term care, and it should be a two-way street. We strongly advocate for care plans where we recommend that we're seeing these patients and define who's seeing them every few months, how long prophylaxis is being continued, and what is the criteria being used to stop them, and thinking about vaccines, which remain a bit controversial, I have to say. The ASTCT has published recommendations for CAR T cells, which actually says you can just revaccinate them as we would after an auto transplant. That is not my practice, in full disclosure. What I actually do is I do vaccinate everybody at least 3 months or later against the respiratory viruses. That's the number one cause of late infections: flu, COVID, RSV. And then when I get to the 6-month mark, I actually check titers. And it turns out most of these patients actually have titers, and patients who have low titers, you can revaccinate. Dr. LaCasce, what's your approach?
Yeah, no, I haven't checked titers, and I worry a bit about the response. I mean, I wonder if you're picking up titers that have been maybe pre-existing, because we generally think after, rituximab or CD20-directed therapy that people may not respond for a year. So I usually wait a bit longer. I think in the setting of the pandemic, we were quick to give it and say, well, there's no toxicity, so we might as well do it. But we don't revaccinate. It doesn't make sense to me. We're not giving ablative chemotherapy. So, and particularly, you've kind of proven it if you're checking these titers. I suspect those are pre-existing titers.
Absolutely. Well, this was I think, a great discussion. I want to particularly thank our contributing general medical oncologist for the cases that really stimulated an extraordinary discussion. I want to thank my wonderful, distinguished friends and panelists, and I'd like to thank all of you for participating today. Have a great night.